Ron go? Okay, good afternoon. In the session on water and fighting disease, my name's Lynn Johnson. I'm a recovering academic and eternal student. And I'm really enjoying the talent level and learning about WASH at this symposium. So I'd like to introduce our two speakers, Peter Van Arsdale and Kevin Andrzejewski, in reverse order of presentation. About Kevin is with the Engineers Without Border and has an MBA in International Development from Colorado State University. He's located here at the Posner Center, as I understand it, working on managing supply chains and his extensive international work in over 25 countries. And we're looking forward to hearing from Kevin. Peter is a professor emeritus from University of Denver, who's an accomplished anthropologist, medical anthropologist, written several seminal books, is worked a lot overseas, has trained students that we've seen some of today that carry on the legacy. And of course, he's one of the reasons why we're here today. This symposium was founded by he and Steve Werner 10 years ago, and really appreciate your participation, Peter. So without further ado, here's Peter Van Arsdale.
Thank you, Lynn, for your very kind remarks and introduction for Kevin and I. We're talking about WASH and water-related diseases. And so I'm going to start, go for about 15 minutes. Kevin will have the remainder, and Lynn will, of course, have time for Q&A. And Lynn will kindly be our moderator for that. By way of background, many of us are interested, of course, in the so-called SDGs, Sustainable Development Goals. And so the two that relate to today's presentation for Kevin and I are Sustainable Development Goal number 3, which gets into disease and communicable diseases in particular, but also such things as sexual and reproductive health. And then Sustainable Development Goal number 6, which specifically focuses on water and sanitation. Now, those students who are here, my former students, know that I always like to talk in threes. So I'm going to begin by recognizing 3 of my wonderful former students who you've already heard from, who are active today. This is marvelous. Katie Troyer, Elise Mann, and Megan Prentice. All 3 of those ladies, I'm privileged to say, were my former students and all have excelled in the work they're doing. The next 3 that I'd like to present has to do with the intersection of 3 of the rotary foci. And these 3 foci, of particular interest to Kevin and I today, and will relate to a couple of things I'm going to share in particular: WASH, maternal health, and disease. Those 3 intersect critically for this. And the next 3 that I'm going to present have to do with the primary causes of these water-related diseases: parasites, bacteria, and of course, virus. So the outline I'm going to give today, which is just an outline of some of the most interesting and concerning infectious and communicable diseases, relates back to those understandings, and certainly to some that are parasitic, some that are bacteriological, and some that are viral. So I put together, just like I used to do in high school when I made poster boards, I decided to make a poster board today. It was fun to make it. I enjoyed pulling out the magic markers and going to town. So here's my poster board for today's session. I have a laser printer, which shows up, a laser pointer, which shows up well for the folks in the audience here, but I don't think shows up well for the folks on screen. But nonetheless, you'll see where we're going. So you notice I've entitled this water-related diseases rather than waterborne diseases, because I'm giving a little broader perspective on diseases and as they relate to water. Not all of these are directly waterborne. All of these have some relationship directly or indirectly to water, water sources, etc. So that's why I've called this broadly water-related diseases. Now, in the somewhat, shall we say, less linked in area, but still potentially water-related, we see in this left-hand column, polio, dengue fever, malaria, river blindness, trachoma, and hepatitis A. And I know for those of you who are medical specialists, you'd think, well, hepatitis A might be moved into the more rather than the less category. That's possibly true. But all of these have, in some degree, some relationship to water and or sanitation and or related hygienic issues. In doing the research for this presentation, I look back at the Sanitary Journal of 1890. Just to let you know, not that they had much about these diseases then, but to let you know that researchers were publishing a journal in the 1890s in English related to the issues of sanitation. That's pretty cool to know. Of course, many more journals today. That was the Sanitary Journal of the late 1800s. And for some of the diseases, they gave them remarkable, ominous names like the kiss of death. Now, specifically, if I could stick for just a few moments to these on the left-hand side of the column, polio through hepatitis A. You folks know a lot about them, and so I'm not going to give a lot of details, but briefly, some obviously, like polio, are viral and particularly relate to stool and stool spread. Dengue fever is also viral, and it's spread by mosquitoes in tropics worldwide. Even, by the way, a few folks in the US have recently contracted dengue fever. And by the way, the symptoms of dengue fever, it hits thousands of people each year, include muscle, joint, and at times more severe bleeding and even shock to the system. But like others I'm going to mention, good news. There is now a new, although restricted use, vaccine for dengue fever. This is exciting news. Still restricted use. It's new, but promising. Malaria, in that sense, is a less, meaning with obviously mosquitoes, but mosquitoes need the water. Thus, I'm putting it in the lesser column. Obviously, water is related to the spread of malaria. It's a protozoan, it's plasmodium, it's parasites, it's parasitic. But the point I want to mention here is a new vaccine. Some of you may have read within the last month, news of a promising vaccine from GlaxoSmithKline. Terrific, interesting news of a new vaccine. We'll see what happens. We're optimistic. Not going to say too much more about river blindness, trachoma, or hepatitis A, but just to say that obviously they're important. They strike people. And you notice I put a red asterisk by dengue fever, malaria, river blindness, cholera, and guinea worm, simply because I have a special interest, as do many of you, in Africa. Those 5 hit Africans hard. Of course, they hit other people too, but since I've been working recently in Africa, I wanted to feature those 5 that hit Africans hard. Trachoma, of course, it influences the eye, affects the eye. Now, let me jump to the bottom of my little poster board for a moment. You'll see the word diarrhea. That's interesting. Diarrhea, some people call it a disease or spectrum of diseases, it's not so much a disease as it is a symptom of diseases, many diseases that induce diarrhea. So it's prominent. I put it at the bottom because it's so prominent. It's not associated with all of these, but with several of these, that we need to remember it. But remember, it's not so much a disease as a symptom of related diseases such as cholera. It's really the most common in that sense, if you think of it writ large. Now, our speaker earlier today appropriately used the term attribution. What do we attribute diseases to? That's the right word. And he hit it, he nailed it. Many of these, not all, have fecal oral links, attributions, as we well know. Stool, fecal material, water, that panoply. Now, let me say something about cholera, and then something more particular about guinea worm. Cholera, as we know, is highly infectious. And I know, having recently, well, 3 years ago, been to Haiti, how many of our Haitian friends have struggled when other things go wrong in complex emergencies, have struggled with cholera. So, of course, people in Africa too, but I just wanted to mention that additional point, that in the context of complex emergencies, these diseases can ramp up. For example, when there's been an earthquake and facilities have been destroyed, as occurred in Haiti. Now, for those of us, at least in this audience here in person, on the left-hand side, I just have a picture of Salmonella bacteria, very common. We're all well aware of it. And of course, that affects certain of these diseases. Guinea worm. Now, the reason I put the picture of the Carters, Jimmy and Rosalind Carter, in part because our good friend Steve Werner has worked with them, but I also want to recognize their work through the Carter Center. And so there's a picture of the president, the former president, and first lady. And then on the right-hand lower, a picture of a team of workers in South Sudan, country very close to my heart, close to the heart of Ray Stransky and many other people who are here today. South Sudan and a guinea worm field team. My student Oliver, 6 years ago, joined the Carter, my former student, joined the Carter Center when he completed his master's degree at Korbel at the University of Denver, and was sent to South Sudan to work on the guinea worm eradication program. So that's why I want to feature this a little bit more. It's what's called an NTD, a neglected tropical disease. Now, in some sense, of course, you could say it's not being neglected. The Carter Center certainly is not neglecting it, but generally in the panoply of these many diseases we're familiar with, guinea worm is somewhat less well known. And again, it's primarily prevalent in places today like Chad and South Sudan. Now, what's very interesting here is that because of the work of folks at the Carter Center and other international agencies, there's a chance, it's remarkable, that guinea worm, after smallpox, could, I say could, become the next fully eradicated major disease / parasitic infection. Wouldn't that be something? They're making tremendous progress. Now, for guinea worm, there's no drug, there's no vaccine. You've got to get rid of the worms, and they come out through the skin gradually, often through the feet. Unfiltered water, no surprise, it's a major contributor. Now, what's very interesting, and that's what I'm going to bring my little introductory presentation to a conclusion before we turn it over to Kevin with his specific examples is this. A classic example of education making a key difference in disease eradication. Guinea worm is a perfect example of where education of local folks, of indigenous folks, working in concert with partnerships, external experts, internal indigenous experts, with education around issues of unclean water, tremendous progress. There's a chance that guinea worm, as I said, could be the second major disease eradicated. Wouldn't that be something? And you wouldn't see, and pardon me for being a little cryptic here, those 6 and 12-inch worms coming out of the feet of people in places like South Sudan. With that in mind, the last thing I want to say is this. Late breaking news I've already given you about vaccines and impending new vaccines. Terrific news. I want to let you know that programs of scale are being addressed by a number of Rotarians. Steve Werner and I, others of our friends can share more with you if you're interested in learning more about Rotary's new programs of scale initiative. Isn't it terrific that one of the first major programs of scale awards for nearly $2 million from Rotary went to the Zambian team? It's called A Malaria-Free Zambia. And they got a huge indigenous-led grant in this new program of scale. That is exciting, and let's wish the best for malaria eradication in Zambia and elsewhere. Thanks very much, Lynn.
Hi, everyone. This is Kevin. Just give me a second to queue up my slides and we'll keep rolling here. All right. Can everybody see the slide? Thumbs up.
We see it here.
Yes.
Yeah, awesome. Well, thank you guys for joining us today. It's been a great event so far. Sorry I couldn't be there in person. I work for Engineers Without Borders, and every year, serendipitously, it's the same day as our annual event. So I've been popping in and out of sessions for both conferences. So, but it's great to be with you guys today to hone in a little bit on going a little deeper on what Peter was talking about. And I'm going to talk specifically today about WASH in healthcare. When I was asked to talk about that subject, it was hitting it spot on. My projects all over the world really focus on better water and sanitation and hygiene in healthcare. But then when they tied infection prevention and control into it, I got a little nervous. But then I realized, all the work we do in WASH, in healthcare specifically, really impacts the stopping of infection spreads. So I'm gonna have a lot of pictures today. I'm a picture focused heavy presenter, but we're gonna come back to this slide quite often because there are so many components that are involved in better WASH practices in healthcare. And so what I wanted to focus on first was who's involved, who's doing stuff, and what is infection prevention control. So according to the World Health Organization, hold on a second, I'm toggling through two different slide decks here. So, okay, there we go. So according to the World Health Organization, infection prevention control is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers. So specifically, again, we're talking about this scenario in a healthcare environment. So, you think about in a day-to-day, especially over the past year, what you're exposed to during your services at a healthcare facility, or if you're one of the frontline workers. So just to give everybody a 101 to remind you of how disease and infections are spread, here are some very common ways, So you think about, you're out in the public or in a healthcare facility, these very easy ways that, you can be contagious or catch an infectious disease. So now we're going to tie this back down into the rural areas of the world that may not have the best sanitation or water services. So here's some statistics. If you do any research on Washington healthcare, you can find quite a bit of different statistics that show that basically it adds up to that there's a lot of people out there who access health clinics that don't have the basic water and sanitation needed to give the proper care. And that gap is huge. And it's something that we can really impact as people and Rotarians. So one fact I like to really point out is the World Health Organization and UNICEF both in 2018 recognized that WASH in healthcare is one of the most pressing but solvable global issues. And I think more so than ever over the past year and a half with the COVID pandemic, we've realized that our healthcare workers and the folks that have to access these facilities need water and sanitation to do their work. Lastly, I have a little quote on there from the Vatican. In the 47 least developed countries, the Catholic Church runs 50% of the rural healthcare system. So if they're putting out a statement like this, it's a very specific need and it's something we need to all address. So now I'm going to talk about the work I do through Engineers Without Borders. We work quite a bit with partners around the world on how to engineer resilience in healthcare facilities. I always like to use this picture. It was taken about 5 or 6 years ago. I was actually in Malawi with Heidi's organization, Freshwater Project International. And I bring up this picture for a couple reasons. You can see there's maybe 20, 30 people sitting outside. And I always ask, why is that? It's because there's another 90 people stuffed in that little building right there and the one next to it. And then I always like to point out how many doctors are on call there today to service those folks. 0. They have a medical professional. That's it. He's not even a doctor. And guess what? The closest water point is behind me to them. I learned on this trip that with that water point being 50, 60 yards behind us, by the time in an open bucket you would take it at the facility, it's not clean enough to use for medical purposes. So coming back to this slide here, there's all kinds of puzzle pieces that need to be put together, including preventive care and just having soap. But it takes partnerships. It takes partnerships at the local level through district health offices and ministries of health to international organizations like Rotary and EWB to come together and figure out a sustainable approach to assure that these rural health clinics can stop the spread of infection disease. So now we're going to go a little bit into some pictures on water and sanitation at these different clinics that we work with. So this is really typical. You see these conditions over and over again in these rural health clinics. And some of these clinics have not seen water for years. So you think about trying to do basic service or birthing at a clinic like this without access to water. So Washington healthcare facilities, the need to have safe and accessible water supply, clean and safe sanitation facilities, and just hand hygiene facilities at toilets and appropriate waste disposal is critical. And as you're going to see through some more pictures here, it's not the most sophisticated designs or technology that's needed. It's basic water and sanitation. So here's just a picture that I like to show that shows some good hygiene measures at one of the hospitals that we've worked with. Again, these areas that we look at are in fairly rural areas, so they're not going to have piped water systems or municipal systems. Often they have boreholes and have to store water for a long period of time. And though, again, just showing the different aspects of what needs to be maintained to prevent the spread of infection in these little clinics. So now we talk about, sanitation a little deeper and as it relates to pit latrines and very basic things that we take for granted, being able to go to a hospital or a clinic and have the basic sanitation services we need. But I'd like to show this picture as well. This is an improved sanitation system actually in a rural village in Uganda. And what I actually really like about this picture is I'm very fascinated with their design, but also the main point is that they have a very small water hand washing station there. That's not common to see that, but I really like to see how simple it can be to have a simple hand washing station to stop the spread. So again, coming back to our puzzle, we're going to go a little deeper now on a couple of these different areas. And what I like to really focus on in my work is, a lot of these clinics, a lot of these rural areas that don't have water and sanitation, us as stewards of wanting to do good and help them get water and sanitation. It's easy to go there and run some pipes, drill a new borehole, but the focus on quality assurance and preventive care and maintenance is something that I really hone in on as I work on our projects. We're only going to be there for a short period of time, working side by side with local technicians and plumbers, but we got to make sure we take care of them. We got to make sure they understand how to maintain it, have basic spare parts and tools to fix any issues. So, as you look at any projects that you want to do, if it's at a rural clinic, at a school, make sure you focus on the preventive care and maintenance side of that as well. And then, sort of outside of the engineering aspect, but a very critical part of the stopping the spread of infectious disease is waste disposal. And I pulled this picture up because I've been probably, I'm guessing, to 70 to 100 clinics in rural areas of Africa and Latin America. I've never seen bins like that. It'd be great if they did have them. But typically, they may have an incinerator or an area dug in the hole that they just have to dump everything. So again, thinking back through, how we can, look at ways to help prevent the spread of infectious disease is ways to better control waste management as well. So now we're getting all those pieces of the puzzle together. And I wanted to go a little bit further then on the preventive care and maintenance part. So as I mentioned before, working with local technicians and plumbers, but also making sure that the parts and the designs you have for these systems are appropriate for the condition. I can't tell you how many times I've been in places and they say, well, our water system is not working anymore because we can't get this part or we can't get that part. So as we at Engineers Without Borders like to focus on is that preventive care, making sure they have the spare parts, the tools, and the knowledge of how to do some very simple fixes. And then preventive care. We've all probably had a plumbing issue at our house or at our office before that could have probably been avoided by just doing some basic care and preventive maintenance to the system. So, that's part of our training is we always like to focus on what it takes to maintain a system before it breaks. So this is just a picture again in Uganda, and you can just tell how rural some of these clinics are and how their water, and you can see, they're powered by very small solar panels. So they may power some lights and a couple small pieces of equipment there. Or perhaps there's a solar powered pump for their water. Very basic things, but that clinic probably has a catchment population, meaning a population around there in the community of probably 30 or 40,000 people that rely on that clinic. So again, coming back to the hygiene part of it, we always love to see people washing their hands. So having access to clean water and hygiene practices and just some basic soap, is I think the first and foremost pressing challenge that we can really focus on. So now I'm sure everybody is going to want to learn more and put a lot of effort in this initiative. So there are so many different ways to do that, as Rotarians. But one suggestion is to start looking at the World Health Organization and UNICEF. They have very specific tools on how to improve wash in healthcare facilities. So if you just do some basic searches on WashFit or World Health Organization wash in healthcare, you're going to come up with a lot of great stuff to read and learn more about how we can impact these communities and help them with better water and sanitation. So I wanted to thank you guys, and I think this is the time we'll open it up to some questions and answers if we have a few minutes still.
Okay, if we have any online, if you would place that in the chat, and if we have any in person, if you'd come up to the microphone. And Kevin, if you'll stop share, there we go. No questions for Kevin or Peter. Kevin, I'm wondering if, and this is a loaded question, but if you'll talk a little bit more about how in your projects you do address preventative care and maintenance with your local implementing organizations.
Yeah, so we're working with this pretty amazing NGO in Malawi. They're called Freshwater Project International. And they have tested and proven, I feel, a really sustainable approach. We use a systems operator. So in these rural communities, you're always going to have somebody who knows how to use a wrench and a hammer. So why not train them a little bit further on how to maintain a healthcare facility? Why not pay them a little bit? And see how that works out. And we've been doing that for about 3 or 4 years. So very basic things of changing out a tap, changing out an O-ring, looking at a toilet and knowing how to put a new part into the toilet. Very basic, but it's been proven through that model on our projects, at least, that these are able to be maintained. Because often, which is the difficult part, is the Ministry of Health at a national level have budgets allocated towards certain things, but 9.9 times out of 10 it never gets down to these district health offices or health clinics specifically. So again, that's why these areas that are in such remote areas but service quite a few people just need a little bit more last mile distribution on some funding and supplies.
All right.
Question here.
I got a good question. Can you guys hear me?
Yes.
I'm Jonas with the African Sustainable Development Foundation in South Sudan, which I'll be talking a little bit about it later. But I just got a good question with Kevin. Kevin, can you hear me? Anyway, let me just go ahead and give my question. So my question is, I know you mentioned, again, my question is, do you guys work in South Sudan, and if so, where? And are you guys working specifically in school, communities, or just general community?
For Engineers Without Borders, we have projects in I think around 47 different countries, and they range from water and sanitation in schools, community boreholes, wash and healthcare is one of our big initiatives. So we partner with communities on a project basis. So if you look at some of the areas we work on, we may be doing a school on one of the projects and then move over to a solar system. We do things outside of WASH, so we do infrastructure in general and different structures.
Kevin, do you want to talk a little bit about kind of the threefold structure of Engineers Without Borders? For someone who, a community or an organization that's local, that's interested in partnering together with you, how does that work and what's the best first step?
Oh, absolutely. Sure. So Engineers Without Borders has several different delivery mechanisms that we utilize. So our organization has staff members, but the heart and soul of our organization are the 10,000 volunteers. We have 10,000 engineers volunteers. And through our international community program, they work alongside communities on a long-term basis. That's our international community program. So there's chapters all around the US, all around the world actually, at universities and professional chapters that work hand in hand with communities on a long-term approach to different projects. And then we have our Engineering Service Corps, which is our seasoned and senior volunteers. And we work with outside agencies like the United Nations or USAID or a local NGO like Freshwater Project International in Malawi. And we work on more of a consulting style basis there. We provide a high level service on design, but we're not the ones actually doing the implementation. And then we actually also have a community engineering core, which focuses on projects here in the United States. You know, there's a lot of underserved communities here as well that we work with.
Thank you, Kevin. Do we have any other in-person questions for either of our speakers?
Yes, I want to make a comment. I'm delighted to see our good friend Joannis here, who's an expert on South Sudan and is from South Sudan. And his work in the broader context of one thing I'd mentioned, a complex emergency is critical as we think about the disease. The other points that Kevin's mentioned about programmatic enhancements. It's the toughest place, as Joannis will tell you, to work South Sudan because of the complex emergency, civil unrest, warfare, famine, locust infestations, corruption among some government officials, et cetera, et cetera. So I want to reiterate my delight in knowing him and in stressing that kind of effort, but pointing out in the context of Washington disease, which is this session's point, how tough that is, not impossible, but how tough it is because of the broader complex emergency that is underway.
Yes, absolutely.
Thank you.
Anytime.
I wanted to show really quick one of the system operators that Kevin had talked about. This is Dalkani. He is a local farmer in Malawi. He lives near Diamfwi Health Center, where we have been working with Engineers Without Borders to repair and upgrade their entire water system. And so Dalkani has been trained in basic preventative care and maintenance of the system. And his job is to ensure that water's up and running at the health center so that the medical professionals can focus on providing safe, hygienic care to their patients. But for him, being a systems operator is a great opportunity because it empowers him with an additional skill to engage in plumbing work, and it provides a second source of income. So far, he reports that he's enjoying his work. And these are the folks that we call our healthcare heroes, because they're in country ensuring that the water systems that the partners have worked so hard on to install continue to be maintained, and water continues to flow to the healthcare facility.
Thank you, Mike McCarthy from Mercer University, and I just wanted to follow up on Peter's comments and what's happening in Jonas this morning. And we talked about complex emergency situations, and also South Sudan, as well as places I've worked like Democratic Republic of Congo and northern Mali. Not only are they complex emergencies, they're often chronic emergency situations where actors never get out of that emergency action. You know, in the saving babies mode, which you think of as first stage emergency. But a lot of the time in maybe I don't know the specifics of South Sudan right now, but in Democratic Republic of Congo, in Mali, you'll get past that first stage emergency where you need to start thinking about sustainability with the actors that are in the money that's coming in from the governments, from the donors is coming in at 6 months at a time rather than 2 or 3 years at a time that you need for development. So I'm glad that over the past several years, we've been talking more in the sector about resiliency and building up the capacity. You know, rather, for example, say in South Sudan, rather than bringing in external well drillers during emergencies to build up the capacities of whether it's for manual drilling or for machine drilling by locals to build up that capacity internally, so that when that next emergency hits, you're better able to deal with it. Thank you.
Thank you so much. I wanted to mention that one of the members of the Rotary E-Club of Wash is working in South Sudan in Wash and villages and communities, and is working on a global grant. So if you will get in touch with me or have somebody give you my contact information, I can put you in touch with him. His name is Jim McGill, and he's working with the CCAP Presbyterian Church. They're focused on washing communities in South Sudan. So I know that there's a lot of people in that area of the world that are focused and concerned and need to connect. And so I'd be happy to try to make those connections. Any other questions?
Looks like we're good here.
Okay, I've got one here from Anthony. Kevin, how do you connect with your organization in Kenya? So do you have-
I think I may have chatted him that, but
Okay.
I'll just mention it as well. You know, our international community program is the best way. We probably have teams that come in and out of Kenya when travel is appropriate, but at the time being, we don't have any staff or permanent volunteers in Kenya at the moment. And as you were reading off that question, I was actually about to type my email address again into the chat box for anyone who'd like to learn more information about any of our work in WASH or what Engineers Without Borders does on an international level or local or our domestic level. I know we have some global people here, or level of work here in the United States as well.
Go ahead, Joanna.
I want to follow up the same, almost a similar question, Kevin, and that is, how do you get a collaboration and partnership with the local group? Like, let's say, for example, I got a local volunteer on the ground, and how do you send your volunteer to emergency places?
So I think if I heard right, how do you volunteer for EWB, and then how we send volunteers to emergency places? Was that correct?
Yes.
Yep.
Yeah.
Yeah. So there's a variety of ways somebody can be part of EWB. I encourage you to look on our website at the different ways, but you know, we have different platforms and there's chapters. You know, the best way to get involved with EWB is, you know, look at where you live and what chapters may be around. You know, in the Front Range of Colorado, we have student chapters at Colorado State University and UC Boulder and Colorado School of Mines. We also have professional chapters that work on these projects. So what you do for that is you become part of the chapter as a volunteer, and you work with a team in a specific community on a long-term basis. You know, then as it relates to how we respond to emergencies, you know, that would be separate to our international community program. You know, through actually the initiative that I work under, which is called our Engineering Service Corps. We partner with UNDP and FEMA and other international medical corps. So those are the partners on the ground. Those are the folks who respond to emergencies in a very quick manner. We partner with them. We're usually not the first ones on the ground. You know, they're usually there getting the layout of the land. And then if there's any need for water, sanitation, or other infrastructure, we can either support that virtually or go in with them, you know, after everything is assessed.
Okay, and I've got one last question from Daniel Nurienda in Malawi. He says, do the systems operators work on mechanized systems?
Is the question, do they work on mechanized systems?
Yes.
Daniel, can you take yourself on mute and maybe explain a little bit what you mean by a mechanized system?
Okay, I wanted to find out if they were like boreholes that are pumps powered by solar or electricity. Are they?
Okay, I think I got the gist of it. He was breaking up quite a bit. But I think he was mentioning things like solar powered pumps, electric pumps. I would say in my experience, that's a little bit more than what a systems operator would do. We would, in the case that I would see is that we would then, elevate that to a district health office, to their electrician or a paid for company. The systems operator does basic things, changes out a tap, an O-ring, maybe you can put some new plumbing tape around a thread. But in our instance, and there's several other organizations and local groups working on initiatives like this. But our feeling is, if it's not a simple fix, then you escalate that to somebody who is a specialist.
Okay. I think we're going to, right at the hour, be beamed back to the Commons, to this room, and the other groups will be coming back as well. I want to thank both of our speakers for being here today, for presenting two different angles on wash and fighting disease. Thank you, Peter. Thank you, Kevin. Kevin, thanks for jumping on in and out of your own international conference today. And we're grateful that you both can share on your areas of expertise and experience. And we're grateful that you could be with us today and keep up the good work.
Yeah, thank you, everyone. It's great to see some familiar faces and some new ones from around the world. And it's actually really good to see a camera shot into the Posner Center. I live about 30 minutes from there, but with the pandemic and stuff, have been working from home quite a bit. So happy and excited to get back in that building sometime soon as well.
And Kevin, is the EWB conference online?
Yep, it's all virtual this year. So.
Okay.
And they have different breakout sessions. There's about 700 people on right now. So
Wow.
Yeah.
Wow.
Something to aspire to.
Exactly.
Well, we got to talk to Steve and the planners to make sure that we don't have it on the same date next year.
Well, I think when we picked the date, it wasn't, there was nothing yet on the calendar. And
Oh yeah, we do everything last minute. So I'm sure we were there.
Yeah, so we'll coordinate that next time to make sure, we've got more bang for our buck here,
Yeah, and I know a few folks were asking in the chat for my email address. I put it in there, so I want to make sure everybody can see it there. But feel free to follow up with me if you have any questions or ideas or want to know how to either get involved or see how EWB could perhaps help out with one of your projects as well.
And EWB-USA.org, right?
Yep. Yeah.
I'll post that in there too. So